My name is Peter Reardon. I'm a third-year emergency medicine resident from the University of Ottawa, and I'm going to talk to you today about video and direct laryngoscopy. Supervisors for this talk were Dr. Christian Yadav from the University of Ottawa and Dr. George Kovac from Dalhousie University. Before we get into it, just want to send out a huge congrats to the R5s who all passed their exam. Congrats, guys. Looking forward to working with you. So we have no conflicts of interest to disclose, and I'd like to start with a case. So I'll get everybody to close their eyes. Picture you're working in recess. It's an evening shift around 8 p.m., and a 75-year-old female gets patched in a recess. She's in significant respiratory distress. She's being bagged with the medics with SATs in the low 80s, and after a brief trial on high-flow nasal cannula and BiPAP, she looks like she's getting very tired and needs to be intubated. What's your plan A? How about your plan B? Does this change if your senior resident calls in sick, or if you're working with an off-service PGY1 who wants the chance to intubate? What if she looks like she's a particularly difficult airway? I'd like you to keep these thoughts in your mind as we go through the talk, and hopefully we'll highlight on some of these points. Objectives today, I want to cover three main questions. Is VL really better than DL? And are there situations where video laryngoscopy can particularly help us? And finally, is there a place for Macintosh geometry video laryngoscopes in RED? And why are we talking about this today? We hear this all the time. We need to own the airway. Emergency medicine, we should be on top of our game when it comes to dealing with difficult airways. But this is a pretty tough job. In the emerge, we have the traumatic airway. We have to deal with C-spine precautions, obese patients with thick necks, contaminated airways. And we do this often with little to no knowledge of the patient whatsoever, and certainly no preoperative assessment. So this translates roughly into a 10% adverse event rate. So the stakes are high. And how do we mitigate this risk? Well, we can look to the Difficult Airways Society guidelines, but their solutions in terms of running into difficulty don't really apply to us because our world is different. We often can't decide to wake the patient up or decide not to intubate altogether. So then came the advent of the video laryngoscope. It's supposed to help us with first pass success and make our job a little bit easier. And since the GlideScope came on the market in the early 90s, the use of video laryngoscopes has taken off. So this is from Brown and colleagues in 2015 from the NEAR registry. Almost 18,000 intubations across the US, Canada, and Australia. And you can see on the top the blue line for direct laryngoscope use has gone down, and proportionally the use of video laryngoscopes at the bottom is conversely rising. But the debate rages on. What's the best device for us? Should we be using the direct laryngoscope, the video laryngoscope? And this is particularly in our backyard as well. So I surveyed our residents in terms of their primary method for intubation, and you can see roughly a 50-50 split. So we can turn to the literature, but this can be confusing as well. We have OR studies, mannequin studies, pre-hospital studies, different experience of intubators, and different types of devices as well. So narrowing down, what we're going to chat about today, our population of studies is going to be emergency intubations on adult patients. So primarily emerge and ICU-based studies. We're going to exclude pre-hospital studies because that has its own inherent difficulties. In terms of our population of intubators, we're going to speak about attending staff and also experienced learners. We're going to exclude primarily medical student studies and anesthetist studies because they may skew our results one way or the other. Our intervention comparator, of course, is VL versus DL. And for all intents and purposes, DL refers to Macintosh laryngoscopy because Miller just isn't used that frequently in our adult population. And our outcome of interest is first pass success. And you may ask yourself, why first pass success and not overall success at intubation? Well, we've seen time and time again that with the increasing number of attempts, we have increasing amount of complications. This is a study from Mort in 2004. It was an anesthesia-run airway team in Hartford Hospital, 3,000 intubations over 10 years. and they compared the relative risk of adverse events of one or two intubation attempts versus greater than 2 attempts. They had a severe hypoxemia rate that was 14 times higher, esophageal intubation increased by 6 times, and a 7-fold increase in the amount of cardiac arrests. Sackles in 2013, this was a U.S. emerge-based study, 2,000 intubations over 4 years. They had a single attempt adverse event rate of 14%, 2 attempts 47%, and a whopping 64% for 3 attempts at airway management. And finally, Kearslock in 2015, this was a Scottish ED study, 7% for a single attempt, roughly doubles at 2 attempts to 15%, and again a 2-fold increase to 3 attempts at 32%. So we know that it's important to get it on the first pass. And for setting the bar, we need to look at our recent data. So Kearslock and Brown, large ED studies, as I mentioned, and Park 2017 is a meta-analysis of 16 ED studies and over 42,000 intubations. And we can see roughly what we're shooting for is a first-pass success of 84%. So with this in mind, we'll get into the literature. The first study we're going to talk about today is from the Cochrane collaboration, so from Lewis and colleagues, published just last year. Systematic review and meta-analysis, and as you can see, they looked. They had a broad search, looked at multiple databases, and they really wanted to see is there any difference between video and direct laryngoscopy. They used randomized control trials only. They excluded mannequin cadaver studies and only adult patients. Their primary outcome was failed intubation and hypoxia, but they also looked at first-pass success as well, among other complications. 64 studies were included in their review, although they identified another 38 in a second search for a revision later on. They didn't include these in the analysis, and 7 ongoing studies. In terms of results, they had a failed intubation rate, an odds ratio of 0.35 favoring video laryngoscopy, 0.39 in terms of hypoxia, and a higher first-pass success rate favoring video with an odds ratio of 1.27. So is this it then? This is our highest level of evidence on the pyramid, a Cochrane systematic review and meta-analysis. Does this put the issue to bed? And really, we need to ask ourselves if this passes the sniff test. So does this really apply to our population? And I think there's significant limitations when we consider that question. In terms of clinical heterogeneity, there's a variety of settings, different types of intubators, different types of devices, and in fact, only 3 actually looked at emergent intubations. Statistically wise, there's wide confidence intervals, a lot of them cross 1, and if you crunch the numbers, the I-squared value is 79%, so significant heterogeneity between values. So these studies probably shouldn't have been combined in the first place. If we step away and look at the studies looking at only emergent intubations, the first study by Griesdale in 2012, this was an ICU-based study. The N was 40 with 20 in each group, and they looked at only inexperienced operators, so either medical students or residents with less than 5 intubations within the last 6 months, and they had a first-pass success rate of 35% for DL and 40% for VL. So I don't think this applies to us. ARIMA in 2014, this was a Japanese pre-hospital study. They looked at cardiac arrest intubations in the field, and they were physician-manned ambulances, and every physician had previous anesthesia experience with over 100 intubations within the last year. So due to both the operator's experience and, again, the very limited patient population, I don't think this applies to us either. But Yeats in 2013, so this was a randomized control trial conducted at Shock Trauma in Baltimore that randomized patients to either direct or video laryngoscopy. And I think this has some relevance for us, so we're going to spend some time on it. So published in the Journal of Trauma and Acute Care Surgery in 2013, they continuously enrolled adult patients requiring intubation. And really their only exclusions were either a strong indication for a surgical airway, like a bad facial smash, or a strong indication for a fiber optic intubation. This would be something like an unstable C-spine injury. Interestingly, at their institution, they were intubating with thiopental or etomidate at the time. They routinely paralyzed their patients, and their primary outcome was mortality, but they also looked at first-pass success as well. Over 10,000 patients came through during their study period. They randomized 900 that required intubation, 900 of them required intubation, but they randomized only 623. So you'll see 320 in the DL group and 303 in the VL group. And although a portion of those were excluded because of their predetermined criteria, you'll note that there's a relatively large proportion that was excluded for no reason at all. So when the authors delved into this a little bit further, they found a few physicians that did not want their patients included in the study. So they did a sensitivity analysis looking at the clinical characteristics and demographics of the patients that were included versus excluded, and they found no difference, so they don't think this affected their results. And this study found that there was no significant mortality difference between the two. And in terms of first-pass success in the middle, 81% for DL and 80% for VL, with no difference statistically between the two. Intubation time was slightly longer for the VL group, and we have to ask ourselves, is that clinically significant? Well, they did do a subgroup analysis looking at the head-injured population and found that there was a 9-second increase on average in the VL group and double the rate of severe hypoxia, less than 80%. So in some situations this may apply, but this was a post hoc analysis, so it's hard to say definitively. Limitations for the study, so of course it was only a trauma population, and there was a small number of intubations by both anesthesia and nurse anesthetists as well. But bottom line, what we're seeing is a large RCT, similar variety of airways that we would encounter, and experienced operators. And we can tell because first pass success is within the ballpark that we're shooting for. And there's no difference in DL and VL. Returning to our objectives, for our first question, we can see that for the majority of airways, VL equals DL. And we're going to see that recur throughout the presentation. But the conflict still persists. And this isn't a surprise to me because there's huge inconsistency in the literature. And we're really seeing no consistent message when the studies come out. To show you an example of this, I created this table. This is all the recent studies looking at DL versus VL in either the ED or the ICU. First pass success is over on the y-axis and the individual studies on the x. And the dots represent the success rate for DL and the triangles for VL. And of course, our benchmark first pass success is over on the right, the black line. So we're seeing that not only is there a huge disparity, there doesn't seem to be a consistent value between the studies, and there is a wider discrepancy with the lower first pass success rates. So there must be something to explain these differences in the studies. And I think for that, we need to look into them a little bit further. No better study to start with than the green in the middle, with both low FPS rates and a wide discrepancy between the two. So this was published by Silverberg in 2015 in Critical Care Medicine. It was an American ICU study, and they didn't routinely paralyze their patients, and these were all patients requiring intubation. Their primary outcome was first pass success, and these were pulmonary and critical care medicine fellows only in this study. They had 150 come through during their study period, and after a small number of exclusions, they ended up with 117. So 60 in the DL group and 57 in the VL group. For first pass success, DL gets a whopping 40% and VL 74%. And these are, of course, statistically different. So what does this study tell us? Well, we have to look at the limitations. And these were inexperienced operators. And when the authors described the training regimen for their first-year fellows, they indicated that they would attend 10 one-hour sessions discussing airway management. So these could be either didactic sessions, simulation sessions. Then at the end of that, they would do an OSCE. And so long as they could pass the airway checklist and intubate the patient, they were able to lead the airway team. So we should ask ourselves, is this enough to be competent in emergency medicine? And to further this point home, 43% of their DL attempts had grade 3 to 4 Cormack-Lehane views, which is significantly, that's very high. They also didn't routinely paralyze, and they did not use stylets. So it may have made their success more limited that way. So overall, this study, what is it telling us? Well, we're seeing that VL seems to be better than bad DL, but there may be a hint that video laryngoscopy can help with our inexperienced operators as well. And to look into this a little bit further, Jans and colleagues published a study in Critical Care Medicine in 2016. This was, again, an American ICU study. They were looking at their pulmonary critical care medicine fellows. And the video laryngoscope they use at their institution is a McGrath Mac, which is a Macintosh geometry video laryngoscope. And they compared that to the classic DL. They had 196 patients over their study period. 150 were randomized, 76 in the DL group and 74 in the VL group. For first pass success, 69% for VL, 66% for DL. But the interesting part about this study is the subgroup analysis. And what they really wanted to look at was experience of the operators, both time in fellowship and experience with the individual devices. And what you'll notice about the numbers is that with less time in fellowship and with less intubations under their belts, the odds ratio seems to favor video laryngoscopy. But as the fellows gain more experience, both time in fellowship and amount of intubations, the odds ratio approaches 1, indicating no difference between DL and VL. So bottom line from these two studies, we're seeing that novice intubators may have improved first pass success with video laryngoscopy. But this doesn't explain all the variation. And I think on that note, we need to think about the situations where we would reach for the DL the most, or sorry, the video laryngoscope. And by and large, most of us would reach for it in the difficult airway. So let's look at how it fares for the difficult airway. So the study is from the journal Emergency Medicine in 2012 by Mosier and colleagues. They're a level 1 trauma center, and it was a prospective observational study. So they collected data after their intubations, and this was stuff like clinical characteristics about the patient, and then details surrounding the intubation as well. So what type of scope did they use, what type of tube, what type of view did they get, and how difficult was the intubation. They looked at their use of glide scope versus Macintosh DL, and they also did a regression analysis after looking at difficult airway predictors, which are listed there, divided up as anatomic and pathologic factors. They had 881 intubations in just under 2 years. Slightly more of these were with the DL. And they had a first pass success rate of 68% for DL and 78% for VL. But looking at the difficult airway predictors, you see that after adjusting for them, the odds ratio becomes less impressive. So we're seeing a little bit of a correlation there that maybe the difficult airways are having more success with VL. But limitations are that this is observational data. We have to ask again, was this good laryngoscopy with a first pass success rate of 68% for DL compared to our goal first pass success? And then also, do difficult airway predictors really help us? Stepping away for a moment to address that point, this study was published in the Journal of Anesthesia in 2015. 190,000 intubations in a Danish registry. And they wanted to see, are anesthetists really good at predicting difficult airways? And in fact, they found that 93% of difficult airways were not predicted. And if they did predict a difficult airway, only about a quarter of them ended up being difficult. Similarly, with mask ventilation, 94% was not predicted, and only 22% ended up actually being difficult if they thought it was going to be. So perhaps we shouldn't focus so much on the difficult airway predictors, but how does this device fare when we encounter a difficult airway? And on that note, we'll look at this study by Vasiliadis in 2015 from Emergency Medicine Australasia. At this center, they used the CMAC device, which is a Macintosh geometry device, and they compared that success to DL. Similar baseline characteristics between groups, but there were a few differences which are listed there. Results-wise, they had 619 intubations over 30 months, and roughly a third of these were for trauma patients, and about a 50-50 split between groups. In terms of results, they wanted to divide up how the operators fared if they ran into a Cormack-Lehane grade 1 and 2, being an easy view, or a 3 and 4, and then look at their first pass success rates. So for their Cormac-Lehane grade 1s and 2s, we're seeing a 95% first pass success rate for VL and 96% for DL. For Cormac-Lehane grade 3s and 4s, and I'll remind you that a Cormac-Lehane 3 is an epiglottis only view, and a Cormac-Lehane grade 4 is no view at all. A first pass success rate of 57% for VL and 30% for DL, which came with an odds ratio of 3.1 favoring video laryngoscopy. This was observational data again. Operator experience varied within the study. And also the difficulties vary with each device as well. So we know that in the majority of circumstances when you encounter difficulty with DL, it's that you're having trouble obtaining the view. But with VL, it's not so much obtaining the view, but it's passing the tube after you get that view. But what we're seeing from these two studies is that VL may have improved first pass success with a difficult airway. Returning to our objectives, VL may be useful in the difficult airway and with less experienced providers. But what about our last point? So, speaking about Macintosh video laryngoscopy, before we get into the literature, I'd like to speak about the different types of video laryngoscopes that are available and the techniques surrounding their use. So these are the types of video laryngoscopes that are on the market. You can see over on the left the channeled scopes, in the middle the optical stylets, but on the right are the rigid blade laryngoscopes, which we're going to focus the majority of our discussion on, because these are the most common in the emergency department. These are things such as the glide scope, which we have here at our center, the CMAC and the McGrath Mac that we talked about during this presentation. This slide represents the different geometry of the scopes. So the Macintosh direct laryngoscope is over on the left for your reference. And this is the CMAC line of devices made by Karl Storrs. And you can see that in the middle is their standard device. And this CMAC has the exact same geometry as the direct laryngoscope. Over on the right is the hyperangulated version. So this is their difficult airway blade, which is similar to our glide scope. And we know that with standard direct laryngoscopy, it's about direct visualization. So aligning the oral, pharyngeal, and laryngeal axes to get direct visualization and be able to pass the tube. And the geometry of the Mac devices allows us to do the exact same thing. If we want to mechanically obtain direct visualization, we can. But there's also a camera on the end for indirect visualization as well. Now the geometry of the hyperangulated blades is really a see around the corner device. So it's about looking around the tissues and up at the glottis for an indirect view to be able to pass your tube. This is the glide scope line of devices. So the hyperangulated version that we have over on the left is what we have at both our centers. And the new Macintosh blade that they've come out with as well. And Dr. Ho is going to pass around some copies that I brought here today. They're disposable blades. So you can really get a feel of the difference between the two. So these are used differently. As I mentioned, the direct laryngoscope is about direct visualization. The standard geometry allows us to do the same. And really, all of our techniques will cross over well. So techniques like extralaryngeal manipulation, burp, whether you want to do a head lift, use a bougie, all of these will work very well with the Macintosh video laryngoscope. But the hyperangulated blades are different. So it's really that rocking motion to look around and look up at the glottis to get your view. But this can come with some problems as well. And I mentioned earlier that the difficulties with these devices are not so much obtaining the view, but passing your tube after. And you can get hang up on the anterior trachea. This is a video that will show you that. It was taken from a cadaver study that was conducted in Halifax in 2012 by Dr. Kovacs, Dr. Murphy, and myself. And we were looking at the success of the King Vision video laryngoscope, which is hyperangulated. And what you're going to see as the operator enters is they're going to obtain this perfect Cormac-Lehane grade 1 view, but then have difficulties passing their tube. So entering in, we see the epiglottis flip up, and 100% eglottic opening. Here comes the tube. And I think we've all run into this problem before. terms of troubleshooting these hyperangulated blades, we can see this slide is from Bacon in 2015. And to get an easier passage of the tube, it's about backing up your scope and tilting your angle down so that you're really looking down the trachea. And what this looks like on your screen is we can see the beautiful 100% view on the left, and actually a worse view when you perform these maneuvers over on the right. And this is what's called the 50-50 view, so a 50% view of the glottis and the top 50% of the screen. But with that, you're going to have a straighter shot down the trachea and an easier time passing your tube. This is a slide depicting the same. So this is with the GlideScope hyperangulated version, the standard that we have. And you can see that in B, when you're up close and getting that view, you need a much bigger bend on your stylet to be able to pass that tube up. And you're going to have quite an angle to traverse to get that down into the trachea afterwards. Versus when you back out, reduce that angle, over on the left in A, much less of a bend in the stylet and the tube that we need. What this looks like on your screen, again, at the bottom, you can see this 100% Cormac-Lehane grade 1 view. And in fact, you can even see the bright white reflection of the cricoid ring in the bottom, which Rich Levitan refers to as the Kovacs sign. And that's really a sign that you're looking up at the glottis and staring at that anterior wall of the trachea. But backing out in the top, the 50-50 view, this is going to allow us a much straighter passage to get the tube in. And manufacturers know this as well. So this is the Pentax Airway Scope. It's a channeled version, so they put in this helpful bullseye for you to be able to pass that tube. And what you'll note about that bullseye is not only is the diameter fairly small, but it's also in the top 50% of the screen. Now it's over to the right, and that's just a function of position of the camera with position of the channel. But what they want you to get is that 50-50 view to get your highest chance of success. And this has been studied before. There was a publication in the Canadian Journal of Anesthesia last year to randomize 150 patients in the OR to either 100% view or a restricted 50% view. And in fact, they had faster intubation times with the restricted view. So now that we've discussed the different types of scopes, their advantages and their drawbacks, we'll move into the literature. We'll return first to our study by Lewis and colleagues. This was in 2016. This was our Cochrane review. And they were looking at the odds ratio for failed intubation. And they found that the CMAC device had an odds ratio of 0.32 compared to the GlideScope at 0.57. And you'll note that in terms of confidence intervals, the CMAC is the only one that's significant. Moving on to emergency studies, the NEAR registry again, I'll remind you, 18,000 intubations across the US, Australia, and Canada as well. They found a first-pass success rate for the CMAC or other MAC geometry blades of 91% versus 80% for the GlideScope and 84% for the direct laryngoscope. But why are we seeing this difference? Are these scopes actually functioning the way we think they are? Can we use them as a direct laryngoscope, perhaps in combination with DL-VL techniques? Well, Sackles and colleagues in 2016, they studied this exact question. And they wanted to look at intubations in their center with the CMAC that they use being used as a direct laryngoscope versus the traditional Macintosh. They had 3,000 intubations over their study period, but only 1,000 met that strict criteria. So they had 346 in the DL group and 671 in the DL group. And what they found for first-pass success for the Macintosh, the traditional DL that we use, 75%. And the CMAC, when they tried it first as a direct laryngoscope, they had 58% success. But within the same pass, if the operator looked over at the video screen, they were able to obtain an overall first-pass success rate of 88%. This came with an odds ratio of 2.9 favoring the CMAC. Now, it's unclear why the operators would change over from DL to VL. Is it because they couldn't complete the intubation, they were having a difficult time, or is there something about the device that doesn't function the same? But the authors propose that perhaps it's just because the screen is there, the views are better, and you're able to quickly cross over. Why would you not use the screen? And this is really supported with their data. So we can see on the left the views they got using the CMAC as a direct laryngoscope, and then in the middle, when they transitioned over to looking at the screen, they found a vast improvement across the board, really, using the CMAC as a VL. But what if that first attempt fails? How do these devices do with rescue? Again, Sackles and colleagues published this. They're an absolute machine at their center. And they were looking at observational data, looking at the CMAC VL versus Macintosh DL for a second attempt. So if they were to fail and reach for a device, how did they perform? And they had around 2,000 intubations over the study period, but of course they excluded first pass success and the same operator, so they didn't want to introduce any bias that way. And for second attempt, they found that the CMAC did much better than the DL, so 82 versus 62%. And this came with an odds ratio of 3.5 favoring the CMAC. And it turns out that whether you use the CMAC first or the Macintosh direct laryngoscope, it didn't matter. In either case, the CMAC performed better for a rescue intubation. So we're seeing that these Macintosh geometry blades are performing better for first pass success, second pass success, and that they can be used as a DL, a VL, or in combination. But they can also help us with teaching as well. This is local data from our emergency staff here at TOH, and I asked what the primary method was for supervising the learner. And you'll see that although the results slightly favor VL, there's roughly a half and half split. And so I would ask those that teach VL, is there a way that you would feel comfortable teaching DL? And for those that teach DL, is there a way that you can make that process safer? To answer this question, I want to turn to Dr. Rob Orman and Anand Swaminathan. This is taken from a ERCast episode in 2013, and here's what they had to say.
If you think about it, so from a resident perspective, put yourself back as being a PGY1 or a PGY2 resident, and you got an airway. So you're pretty excited. Your adrenaline is going. The whole time that you're trying to intubate the patient, your attending is standing over your shoulder saying, what do you see? What do you see now? Wait, what do you see? Wait, do you see something? What do you see? Do you see something now?
Being the attending who's saying that before the day of video and they grab the tube, you're asking, do you see the cords? Do you see the cords? And you know when they don't actually see the cords or don't really see the cords, but they say yes?
Yeah, exactly.
Oh, it's so frustrating.
That's it. It's exactly what it is. From the attending perspective, obviously we've had the ability to be on both sides of this. From the attending perspective, the resident's trying to intubate, and all you want to know is, what do you see? I've had a resident say, I've got a Cormac Lehane grade 2, and I'm like, I don't know what the hell that is. I have no idea what you're talking about. Just tell me what you see. And this, video takes it out of the mix. Video, I can see what they see. So I know if they're struggling. I know if they found the epiglottis. I know if they have any idea whatsoever where they are. From being in an academic place for so long, I don't get to do a lot of intubations now. I have really skilled residents that get the vast majority of the intubations. So there's some times where I'm sitting there and I'm like, I haven't tubed anyone in about 6 months. And the resident's in there, and it's been about, I don't know, maybe 8 or 9 seconds. So I'm like, well, why don't you step out of the way and let me take this one, since you have no idea where you're going. With video laryngoscopy, though, I see what they see. I know what they're looking at. I know what their struggles are. And I know if I can give them a little extra time.
I asked our anesthesia colleagues what they thought of these devices as well. And I received this opinion from Dr. Rob Chen. He's an anesthetist and intensivist over at the Ottawa Heart Institute. And I'll read you his quote. So he said, the reason that glide scopes fail is that the anterior larynx is connected to a trachea that goes inferiorly. The endotracheal tube is forced to take a harsh angle anteriorly and then travel inferiorly. And the second direction is often where it gets stuck. Mac geometry keeps everything in line and therefore a good view, which equals easy passage of the endotracheal tube. So he was very much in favor of these devices. Bottom line from this section, we're seeing that Macintosh video laryngoscopes may have improved first and second pass success in ED intubations, that the geometry allows it to be used in either fashion, and it could provide a safer setting for teaching DL as well. Returning to the 3 questions from today, we can see that VL equals DL for the majority of situations, but there are some situations, perhaps a difficult airway and with less experienced providers, that VL may help you. But in the end, Macintosh video laryngoscopes may be optimal for our environment. I want to ask the opinion of our Canadian airway experts as well. So I asked Dr. George Kovacs from Dalhousie University to give his opinion. And for those of you who don't know, Dr. Kovacs is a professor of emergency medicine. He's also cross-appointed to the departments of anesthesia, neuroscience, and medical education as well. And he runs the AIM Airway course in Canada, being the co-developer and director as well. And here's what he had to say.
Hey Peter, great rounds. I reviewed your slides. You've clearly done a ton of work, so congrats on that. You've asked me to answer two big questions in a very short period of time. I'm going to try to do this in under 3 minutes. Your first question was, what should be our primary device for intubation? And maybe this is going to sound like I'm avoiding answering the question, but it's really not. You can use a direct laryngoscope successfully. Our air team, critical care medics have over a 90% first pass success rate with very low complication rates of hypoxemia and hypotension using a direct laryngoscope and a bougie. And if you optimize use of a direct laryngoscope and a bougie, it's going to be hard to beat, quite frankly. You can have high success rates with any type of video laryngoscope, and it's an unstoppable movement. I appreciate that. But you can't be good at one without the other. So in other words, when my video laryngoscope fails, often what I'm going to have access to is a direct laryngoscope. So you can't have an option A without being good in option B or option C. So it's about being good with all your devices, and whether you choose your primary video or direct, you can be very successful. Your other question was multiple VLs that are out there. What do I suggest we use? Again, I go back to saying that it's not the device. We're looking for easy, and there is no easy in airway management and emergencies. And the device is not going to be the answer. It's going to be the skill of the person using the device is going to be the answer to challenging airways. I think that the literature supports Macintosh, standard geometry, Macintosh video laryngoscopy, and the nice thing about that is it's skill transfer from direct laryngoscopy to use of the Macintosh video laryngoscope. So I think that that's really the way to go. The device that's been on the market for the longest is the CMAC, and it comes in both a hyperacute angle blade with the D blade and their standard Mac blade. It's a great quality device. The GlideScope has been on the market for only a short period of time in terms of their Macintosh blade, and I think they have a bit of problem solving to do with it, but it's a reasonable option, as is the McGrath Mac, which I know that they're going to come out with an improved version in the next year or so. So that's my answer to that. But again, using the analogy that Rich Levitin uses, is that when the airbag came on the market, we didn't give up using seatbelts. So you've got to have more than one option to save lives, and be good with whatever that option is. Congratulations on some great rounds.
So returning to our case, remember that elderly female that entered our department in severe hypoxemic respiratory failure. What would be your primary approach, or your plan B if that fails? What if you had a different learner or a different type of airway that you encountered? And hopefully this talk has helped highlight on some of these points and clarify that for you. What I see for future directions for our center is that Macintosh video laryngoscopes be used for the majority of our ED intubations. I'd like to finish with a quote. This is sometimes used by Dr. Kovacs in his talks, and it's from Mike Tyson. It's that everybody's got plans so they get punched in the mouth. And I think nowhere does this apply better outside of the ring than with emergency airway management. Because what we're seeing in all these studies is that no device has 100% first pass success. And if our plan A is successful 85% of the time, we need to be good at our plan B 15% of the time. So we need redundancy in the system for the safety of our patients. So I'll end there, but I want to acknowledge some people who have been instrumental in the talk. Dr. Christian Yadav and Dr. George Kovac for supervising the talk, Dr. Rob Chen for his expert commentary, Dr. Rajiv Thavanathan for not only helping with some AV issues, but also generously donating his picture of the difficult airway, Dr. Ashling Fitzpatrick and Dan Belvo for listening to my talk more times than they wanted to, and Dr. Mark Reardon for bouncing ideas back and forth when thinking about the topic. Kerry Poulain also helped with finding some local data as well. So I'll end there, and I'll take any questions.